Now we are going to discuss the thyroid malignancies, now the important topic for PG aspirants. So may not be so much important for final years, but for PG aspirants it's one of the high yield topic for exams. So thyroid malignancy, before going into thyroid malignancy, let me tell you the Dunhill classification. Dunhill classification of thyroid malignancies. So the malignancy classification by Dunhill is well differentiated cancers. Please remember, well differentiated cancers and medullary cancer, and undifferentiated cancers. Undifferentiated cancers. So these are the types of thyroid malignancies. In differentiated cancers, the cancers we have are papillary cancer, follicular cancer, and Hurthle cell cancer. And undifferentiated, the cancers we have is anaplastic cancer. Anaplastic cancer is an undifferentiated cancer. So very important for exams, especially for sequence-based questions, you should know the percentage of malignancy in each. So the percentage of malignancy given in Valiant Love is 80% for papillary, so 10% for follicular. Please remember, the 80% for papillary, 10% for follicular, and for medullary they give 2.5%. Anaplastic it is 5%. And there is one more other rare cancers like lymphoma. We get non-Hodgkin's lymphoma in thyroid, NHL. NHL type of lymphomas are seen in thyroid. It is only 2.5%. So the sequence-based questions are, so from Valiant Love, what is there in Valiant Love? Just I'm telling you the order in Valiant Love. Papillary 80%, second follicular, third anaplastic, medullary is 2.5% only. So lymphoma is 2.5%. This is a sequence-based question you can get in AIMS. So please don't forget Dunhill classification of differentiated thyroid cancers. Now coming to predisposing factors or predisposing things for this malignancy. So are the etiological factors of malignancy. So please don't forget long-standing multinodular goiter. Long-standing MNG can go for malignancy. What malignancy can it go? Long-standing multinodular goiter can go for follicular cancer. So I'm telling you what are the predisposing factors. And irradiation is a predisposing factor of many malignancies, including papillary cancer of thyroid. Papillary cancer of thyroid. And I told you already, Hashimoto's is a pre-malignant condition for what cancers? Hashimoto's is a pre-malignant for NHL, non-Hodgkin's lymphoma, and papillary cancer. And I already told you one of the complications of thyroglossal cyst can go for what cancer? It can go for papillary cancer. So you can see papillary cancer is predisposed by Hashimoto's, thyroglossal cyst, and irradiation. So many predisposing factors for papillary cancer. And apart from all these things, the important thing you should know is genetic mutations causing cancer. Genetic mutations and syndromes causing cancer of thyroid. So please don't forget the following interesting MCQs. Red oncogene mutation. Red oncogene mutation is associated with which cancer? Can you tell me? Red oncogene mutation is associated with medullary cancer of thyroid. RAS mutation. RAS mutation is seen with mainly with follicular cancer, can also be seen with papillary cancer. Follicular, more common than papillary cancer, can get RAS mutation. Okay, RAS mutation. P10 mutation. P10 mutation is also seen with follicular cancers. And very well known MCQ P53. The P53 mutation is seen in anaplastic cancers. So and you all know very well the various cancer causing syndromes. The cancer causing syndromes of thyroid cancer are Cowden syndrome or Cowden disease is one cancer causing syndrome. Familial adenomatous polyposis is another cancer causing syndrome, and MEN2A and MEN2B syndromes. Please don't forget, this is more important. What is the name of MEN2A? So please don't forget MEN2A, the other name is Sippel syndrome. Okay, MEN2A Sippel syndrome can cause thyroid cancer. What other? Corney's triad. McCune-Albright syndrome. So McCune-Albright syndrome, all these cases can cause thyroid cancer causing syndromes. So though not so important, I want you to remember only about MEN2A and MEN2B syndromes. So MEN2A and MEN2B will be discussed in detail in endocrinology chapter. I am just giving you the outlines here. So MEN2A is associated with medullary cancer thyroid. Is associated with pheochromocytoma. It is also associated with hyperparathyroidism. Please remember, it is also associated with hyperparathyroidism. Whereas MEN2B is associated with what are the features? Medullary cancer thyroid. It is associated with medullary cancer thyroid. It is associated with pheochromocytoma. It does not have hyperparathyroidism. Instead, it has marfanoid habits. Marfanoid habitus and mucosal neuromas. Neuromas are present in MEN2B. And in MEN2A, there is one disease seen. What is it? Very interesting GIT disease. Hirschsprung disease. Hirschsprung disease is seen. So MEN2A, MEN2B syndromes are associated with medullary cancer thyroid. Therefore, norms advise prophylactic thyroidectomy for both patients. They advise prophylactic thyroidectomy for both the cases. So in a MEN2B patients, they advise at around 6 years. But in MEN2A patient, they advise at around 1 year. See, MEN2B, they advise prophylactic thyroidectomy at around 6 years. And MEN2A, they advise in the infant period itself. So that's a high risk of malignancy seen in MEN2A and MEN2B syndromes. So please don't forget MEN2A, MEN2B syndrome as a predisposing factor for malignancy. So now I'm going to discuss in simple way the various cancers. Before going to cancers type, I want you to know about the thyroid cancer staging, because this is nowadays the national board examiners are asking questions from staging. So just let us have an outline of the staging. T1A, T1B. So please remember T1A and T1B. Very simple staging for thyroid. So T1A is less than 1 centimeter. So T1B is 1 to 2 centimeters. So T1 is, in otherwise, like a skin cancer, it is 1 to up to 2 centimeter. Up to 2 centimeters is T1. So T2 is 2 to 4 centimeters. T2 is 2 to 4 centimeters. T3 is more than 4 centimeters. Interesting point is not only more than 4 centimeters. It may involve surrounding muscles and soft tissues. It will involve the muscles, soft tissues is involved by T3. So coming to T4A, it involves subcutaneous tissues like larynx, trachea, esophagus, and also recurrent laryngeal nerve. So you can see recurrent laryngeal nerve, trachea, esophagus, larynx, all come under T4A. T4B is involvement of carotid and mediastinal vessels. Carotid vessels or mediastinal vessels. So I want to tell you one important point in T4B which may be asked in exam. T4B is the one which invades prevertebral fascia. So it invades prevertebral fascia. See, it is going near the vertebra and invading prevertebral fascia is T4B. So prevertebral fascia is invaded. So this is T4B. And nodal staging is not much important. N1A is, say, level 6 nodes are involved, and above 6 node is N1B. Only N1A, N1B. Only 2 nodes. N1A is level 6 nodes and beyond 6 nodes. So in otherwise, the staging is very simple. Please don't forget, TNM staging is not so important, not asked in exam so far. But since there is an upcoming so many questions from staging, I am putting TNM staging. Otherwise, I will never take TNM staging for thyroid cancer in my lecture classes so far. So TNM staging, T1 less than 2, less than 2. T2, 2 to 4. T3, more than 4 with involvement of soft tissues and muscles. Soft tissues and muscles. T4A is removable structures. What all structures you can remove? Like larynx, you can remove. Trachea, if it is invading, you can remove. Esophagus also you can even remove sometimes. So T4B is non-removable structures like common carotid artery, mediastinal artery, and prevertebral fascia. So N1A is only level 6 nodes. What is the name of level 6 nodes known as? They are known as pretracheal or prelaryngeal nodes, also known as delphic nodes. Involvement of level 6 is known as delphic nodes, and N1B is beyond level 6 nodes. Beyond level 6 nodes is known as N1B. So please don't forget, these are the TNM staging I want you to remember. TNM staging I want you to remember for your exams. So please don't forget these stagings, TNM staging for exams. So now I'm going to the proper thyroid differentiation points. I'm going to tell very interesting points between papillary cancer and follicular cancer. So just differentiating, I'm going to differentiate papillary cancer and follicular cancer step by step. Pap CA and follicular CA. We are going to discuss one by one now. Okay. Follicular CA and Pap CA we are going to discuss one by one now. So papillary cancer is the most common thyroid cancer. It's the most common thyroid cancer. Follicular cancer is the most common thyroid cancer in where? Most common thyroid cancer in iodine deficient areas. In iodine deficient areas, follicular cancer is common. In iodine deficient areas. So papillary cancer is the most common thyroid cancer. Follicular cancer is the most common thyroid cancer in iodine deficient areas. Iodine deficient areas. First point. So papillary cancer pathology. What are the points in pathology you should know in papillary cancer? So pathology of papillary cancer. Papillary cancer is multicentric in nature and it can be multifocal in nature. Multifocal means within one gland there are many lesions. Multicentric means in both glands there are lesions. So multicentric means in both lobes. Multifocal means it is in one lobe, so many mets, and it may or may not have capsule like this. It may or may not have capsule. But follicular cancer is usually solitary lesion. Please remember, it is usually a solitary lesion, and it will always have a well-defined capsule. That is a classical point. Follicular cancer has well-defined capsule present. So papillary cancer is multicentric, multifocal. Follicular cancer is single with a well-defined capsule. Papillary cancer and follicular cancer discussing the pathological features. Papillary cancer spreads by lymph node mets. Most common mode of spread is lymph node mets. And in this lymph node mets, you must remember 100 times asked MCQ known as lateral aberrant thyroid. What is this lateral aberrant thyroid? What is this lateral aberrant thyroid? So please don't forget, lateral aberrant thyroid is a term given for a patient presenting to you with a node in the neck. There is a patient coming to you with a node in the neck. FNAC shows it is positive of malignancy and it is papillary cancer malignancy. But on palpation, no gland is seen. So it is nothing but metastatic node. In single line, if you want to tell, it is metastatic node from an occult papillary cancer. Metastatic node from an occult papillary cancer. That is answer for this word. Occult papillary cancer. It is a misnomer. The name lateral aberrant thyroid is a misnomer. They have named it wrongly. That is the point I want you to remember. It is a metastatic node from an occult papillary cancer. Lymph node mets are common in papillary cancer. Whereas follicular cancer, hematogenous mets are common. In follicular cancer, hematogenous mets, they spread more by hematogenous root. They spread more by hematogenous roots of met is common in follicular cancers. And can you tell me what is the most common site of hematogenous spread of follicular cancers? The most common site of hematogenous spread of follicular cancer is to skull. Skull. It produces what type of mets in skull? Yes, what type of mets you get in skull? Pulsatile. You will get pulsatile, osteolytic secondaries are seen in skull. So the most common spread of metastasis in follicular cancer is to skull. It is a pulsatile secondaries. So distant mets in papillary cancer is usually to lungs. So please remember, papillary cancer is to lungs, and for follicular cancer, distant mets is to skull. It is to skull. Distant mets is to skull in follicular cancer, lung in papillary cancer. So please don't forget, this is a very important topic. You should not forget. And I already told you about the FNAC. FNAC of papillary cancer. What is the finding? There are 3 P in papillary cancer. They are nothing but samoma bodies. Samoma bodies are nothing but concentric calcifications. Samoma bodies are concentric calcifications. Pale, empty, orphan unni-eyed nuclei. I'm going to show you that nuclei. Pale, empty, orphan unni-eyed nuclei. Papillary projections. Papillary projections. So samoma bodies, pale, empty, orphan-eye nuclei, papillary projections are the findings in FNAC of papillary cancer. FNAC of papillary cancer. The findings are samoma bodies, pale, empty, orphan-eye nuclei, papillary projections. FNAC of follicular cancer is inconclusive. Please don't forget, FNAC of follicular cancer is inconclusive. We cannot differentiate whether it is benign or malignant because the malignancy is based on capsular invasion, which cannot be detected. Capsular invasion is present, which cannot be detected by FNAC. So FNAC is not useful in finding it out. Okay, FNAC points. Okay, then coming to the predisposing factors. Already I told you the predisposing factors also. Here it is irradiation, Hashimoto's. What are all the predisposing factors? Means irradiation, Hashimoto's, and one more, thyroglossal cyst. And for follicular cancer, it is long-standing multinodular goiter. It is long-standing multinodular goiter is the only predisposing factor of follicular cancers. Okay, so I want you to remember these points, very important differences. And papillary cancer has excellent prognosis. Okay, excellent prognosis of around 95% survival in 10 years. Okay, and follicular cancer is also having good prognosis. It's not having any bad prognosis. It's also having good prognosis. It is also having good prognosis. It is also having good prognosis. And treatment of papillary cancer is straightforward because it is a clear-cut malignancy FNAC diagnosed. So the treatment is total thyroidectomy plus modified radical neck node dissection if nodes are positive. If nodes are positive, we should do also modified radical neck node dissection, total thyroidectomy plus modified radical neck node dissection if nodes are positive. So for papillary cancer, but for follicular cancer, the treatment is little complicated because it is not sure, you're not sure whether it is benign or malignant. So what we will do therefore, see what I'm going to do like a story. So now a patient comes to you with a nodule on the right lobe. The nodule becomes as follicular neoplasm on FNAC, that is Thy3 on FNAC, Bethesda Thy3. So what I will do, I will now remove only half of the gland. I will remove this half of the gland and send it for histopathological examination, not frozen section. Please remember, frozen section concept of thyroid is not so effective. Many times frozen section does not pick up the malignancy. So we send them for histopathological examination and the result comes in 2 to 3 days, the result comes. If it is benign, that's all, patient can be discharged home. If it becomes malignant, on histopathological examination, reopen it and do what? I will reopen it and I will do completion total thyroidectomy. That is the protocol. Completion total thyroidectomy. So please don't forget, finally, this is a very important point you should note in exams. So if it is a malignant on histopathological examination, you should reopen it on the 3rd, 4th day itself and you have to find it as malignant. You have to remove the entire gland. On follicular cancer, unless nodes are involved, no need of nodal dissection, unless nodes are involved. So for both cancers, now surgery is completed. Let us assume for both of these guys, total thyroidectomy is completed for differentiated cancers. Total thyroidectomy is completed. Total thyroidectomy done for papillary and follicular cancer. What should I do in the post-operative period? Post-operative period, I should look for meds. What will I do? Look for meds. I will do radioactive iodine uptake study. Why don't I do this before surgery for meds? Why should I do it after surgery? Because if I do this radioactive iodine uptake study before removing the thyroid gland, the meds will not be shown. Only the thyroid gland will take up all the radioactive iodine and meds cannot be picked up. Therefore, I will do this radioactive iodine uptake study in the post-operative period. After removing total thyroidectomy only, I will do this test of radioactive iodine uptake study. Please don't forget this point. So post-operative, after operating differentiated thyroid cancers, what you should do is, I will do radioactive iodine uptake study. This is an expected 100 times asked MCQ. So iodine 123 or 31 radioactive iodine uptake study. And if it is showing meds, what will I do? If it is showing meds, now I will do radioactive iodine ablation therapy. I will do radioactive iodine ablation therapy with higher doses. If there is no meds, I will send them home and keep them on follow-up. If there is no meds, send them home and keep them on follow-up. Follow-up is done with a tumor marker known as what tumor marker? What is a tumor marker? The tumor marker is thyroglobulin. Is a tumor marker of follow-up. So the patient will be in follow-up with thyroglobulin. So whenever the thyroglobulin level elevates, we should do again radioactive iodine uptake study. Whenever thyroglobulin level is elevated, we have to do radioactive iodine uptake study to look for meds. So this is the protocol in the management of differentiated thyroid cancer. So please don't get confused in papillary and follicular, because even final students, examiners will get upset if you don't know the management and protocol for papillary and follicular cancers. So now at the completion of these cancers, please remember papillary cancer is TSH dependent cancer. After total thyroidectomy, papillary cancer is TSH dependent. Therefore, if you suppress the TSH, the cancer will not come back. To reduce the recurrence or med, suppression dose of thyroxine is given. Suppression dose of thyroxine means how much will you give? Can you tell me? Supplement dose, how much we give? 1 tablet, 0.1 milligram, 1 tablet. Here, 0.3 milligram tablet is given for suppression. 3 tablets are given as a suppression dose. But after total thyroidectomy, the patient is having no thyroxine production. Now we have to give substitution dose in. Substitution dose is given for follicular cancer, and for substitution we give 2 tablets, 0.2 milligram. So please don't forget about the different tablet doses. So suppression therapy is 3 tablets, substitution therapy is 2 tablets, supplement therapy is only 1 tablet. So substitution dose is done after total thyroidectomy for other cancers. Suppression dose is indicated only for papillary cancer. This itself is an MCQ. Why should I give suppression therapy? Means because papillary cancer is TSH dependent cancer. It is TSH dependent cancer. So I should give suppression therapy. I want you to remember this for exams. Okay. So now, when I'm discussing about papillary cancer and differentiated cancers, I should tell you about AGES scoring system, AMES scoring system, MASES scoring system. These are the scoring systems given in SWOTs. So AGES, YAMES, MASES scoring system. What is the purpose of these scoring systems? These scoring systems will tell whether the patients are low risk patients or high risk patients. Low risk and high risk thyroid cancers is differentiated by AGES, AMES, MASES. AGES, AMES, MASES. A for age. Age less than 40 years is low risk and more than 40 years is high risk. Okay. Yes, that S stands for sex. Female sex is low risk. And for male, it is high risk. Male, it is high risk. Metastasis, M for mets. If mets is absent, it is low risk. If it is present, it is high risk. Okay, so I'm telling you the expansion of each word given in the material. So G for grade. So we have different grades of tumor. If it is a well-differentiated tumor, it is low risk. If it is a poorly differentiated tumor, it is high risk. Then very important, what you can get in your exam is from the size. Size less than 2 cm is low risk, and for more than 4 cm it is high risk. That is why follicular neoplasms of more than 4 cm we directly go for total thyroidectomy. This is an MCQ. Follicular thyroid neoplasm, Thy3 on FNAC. It is looking more than 4 cm means directly you can go for total thyroidectomy. No need of any followed by completion. More than 4 cm, directly go for total thyroidectomy in a size because it is high risk. And what other word we need? Expansion. Extent of the tumor. Extent. It is confined to the thyroid gland. It is coming out of the thyroid gland. Out of thyroid gland. There is expansion out to the capsule. Capsular invasion present. Its present is extent. Okay, so extent is E. And C for completeness of surgery. C for completeness of surgery. So completeness of surgery, it's complete, it is incomplete. Micro residual tumor is present. R1 positive. R1 means microscopic residual tumor is present. So this is a grading system. AGs, AMEs, MASES are the grading systems used for various cancers. Okay, so please remember this grading system. In this, what you can expect in MCQ is you can get question from size. Size less than 2 cm is low risk, more than 4 cm is high risk. Less than 40, female is low risk. You can get question from this. Following are low risk factors according to AGS grading, AMES grading like that. You can get questions. So please remember this point. So this one I want you to remember this points. So papillary cancer, anyhow, the treatment is going to be total thyroidectomy, and for follicular cancer, the treatment is going to be depends as I discussed. You have to go for ME followed by completion thyroidectomy. So last differentiated cancer is Hürthle cell cancer. So Hürthle cell cancer is a very rare variant of follicular neoplasm. It is a rare variant of follicular neoplasm. So interesting point about Hürthle cell cancer is, like follicular neoplasm, malignancy is indicated by capsular invasion. Malignancy indicated by capsular invasion. Same like follicular cancer. So therefore FNAC is not useful for these guys also. Earthy cell cancer also FNAC not useful. So FNAC is not useful. Whereas other interesting points are, what are the differences of this from follicular neoplasm are, it is derived from oxyphil cells. The differentiating points are, it is derived from oxyphil cells of thyroid gland. It is, do not take up radioactive iodine, not takes up radioactive iodine. So what are the points which are different from follicular cancer? Oxyphil cells not takes up radioactive iodine. It is multifocal tumor, multifocal and multicentric or bilateral. Multifocal or multicentric or bilateral. It is more of lymph node mets are present. Lymph node mets are present. And as I told you, follicular cancer is good prognosis, but this fellow is bad prognosis. They have 20% mortality at 10 years. 20% die in 10 years. So it is poor prognosis. Mortality is high. So please don't forget, earthy cell cancer is a variant of follicular cancer derived from oxyphil cells, not takes up radioactive iodine. It is multifocal lymph node mets are present. So these are some points like multifocal lymph node mets are more like papillary cancer. Okay, so please don't forget these points. And treatment of earthy cell cancer is always total thyroidectomy. So total thyroidectomy will be done for earthy cell cancers. And if there is no involvement present, we should do modified radical neck node dissection. And at this point, I would like to tell you one important neck node dissection known as central neck node dissection. CND. Central neck node dissection is removal of level 6 nodes on both sides. Pretracheal and pretracheal nodes on both sides should be removed, or otherwise nodes between hyoid above, clavicle below, sternocleidomastoid on both sides. So when you remove all the nodes in this area, hyoid bone, clavicle, sternocleidomastoid, all the nodes between this are removed is known as central neck node dissection. This is also advised for earthy cell cancers. This is advised for earthy cell cancers and for medullary cancer thyroid. So all earthy cell cancer, all medullary cancer thyroid, we should do central neck node dissection. Please don't forget, we should do central neck node dissection. So now these are the interesting points in differentiated thyroid cancer. So I am discussing differentiated thyroid cancers of Dunhill's. So Dunhill's post-operative management. Post-operative management of differentiated thyroid cancer is a separate short note for super specialty PG, MS aspirants. Post-operative management of thyroid cancers. So I told you, after total thyroidectomy, what you must always do? You must always do radioactive iodine uptake study to look for METs. And if METs are present, we treat them by radioactive iodine therapy is given. Please understand this first point. Always we must do this. So the question is, what are the indications of radioactive iodine therapy? Indications for radioactive iodine therapy in the post-operative period. So this is an expected short note for PGs, MS PGs. So please remember, what are the indications of radioactive iodine therapy? So in a radioactive iodine uptake, there is a distant METs present. This is what you know very well. When there is distant METs present, or when there is an extrathyroidal spread present in your biopsy, there is extrathyroid spread is present. Okay, spread is present. When the size of the tumor is more than 4 centimeters size of tumor, the size of the tumor is more than 5 centimeters. I told you already. Lymph node METs are present. Lymph node METs are present. And the papillary, this is a very interesting point. When the papillary cancer is having some variants, papillary cancer of thyroid has some high risk variants. Like what are the variants? Tall cell variant, insular variant, columnar variant. So these are some variants which are having high risk. So what are the indications of radioactive iodine therapy? The radioactive iodine therapy will be given in a dose of 30 to 100 millicuries will be given. 30 to 100 millicuries will be given radioactive iodine therapy. So this therapy is indicated for these cases. This is a expected PG level Ames question as well as question for surgeons. So distant METs, extrathyroidal spread, size more than 4 centimeter, lymph node METs are present, or when the papillary cancer is having tall cell, columnar, insular variants. So what are the other things you should do? One is this. The next one is the second line treatment apart from radioactive iodine is radiotherapy, external beam radiotherapy. We can do EBRT, external beam radiotherapy for METs. Where there is a localized METs in the skull, we can give external beam radiotherapy to the METs. That also can be done for especially follicular cancers. So then we can give chemotherapy. Though chemotherapy is not much effective in thyroid cancer, still there are some places we advise chemotherapy like doxorubicin, paclitaxel, and paclitaxel are advised. Okay, and still there is hormone therapy available. I already told you hormone therapy, which is an hormone dependent cancer in this list. TSH dependent cancer is papillary cancer. So therefore, for papillary cancer, which is hormone dependent, TSH suppression therapy can be given with thyroxine in a dose of 3 tablets. 3 tablets can be given. So please remember that. What are the other managements? Post-op management. Number 1, radioactive iodine therapy. So we will give radioactive iodine therapy, we will give external beam radiotherapy, we will give chemotherapy and hormone therapy. So this is about the well-differentiated thyroid cancer management. So please don't forget, what are the well-differentiated thyroid cancer management? So you should not get confused in papillary cancer, follicular cancer, and earthy cell cancer. Are you clear with this 3? Only when you are clear with this 3, I will go to the other cancers. Papillary is having more of nodal metastasis. One such nodal metastasis is known as lateral aberrant thyroid. Follicular cancer produces more of skull METs, pulsatile skull METs. Follicular cancer is FNAC not useful. Papillary cancer FNAC has excellent MCQ points, orphan and nuclei, samoma bodies. So please don't forget these points. Okay. So if you are clear with this, we are going to go into the next topic on medullary cancer. So I hope you are clear with the differentiated cancer. Now I am going into the medullary cancer of thyroid. So very important topic for PG aspirants. The medullary cancer of thyroid is a high yield topic for PG aspirants. The incidence according to Bayesian law is 2.5%. So like to tell you 2.5% according to Bayesian law. So it arises from, the interesting point is, it arises from parafollicular C cells. Okay, which are derived from ultimobranchial body. So please don't forget, this is derived from ultimobranchial body. It is associated with red oncogene mutation, and associated syndromes are MEN2A, MEN2B syndromes, which I already told you. Okay, so now when you differentiate the medullary cancer, it can be divided into sporadic cancers. Sporadic cancers are most common, 80%. They are most common, and they are usually unilateral. And familial is around the remaining percentage. Okay, so familial is around 20% of the patients, and familial type of medullary cancers are mostly bilateral, multicentric, multifocal. They are mostly multicentric and multifocal cancers. So please don't forget. So the familial cancers are associated with MEN2A syndrome, MEN2B syndrome, familial medullary cancer syndrome, familial medullary cancer thyroid syndrome. Like that, there are many familial causes of this cancer. So please don't forget. Anyhow, still the commonest type is sporadic. So mostly they are unilateral and they are the most common type. Familial types are 20% only. So now coming to the properties of this cancer. Properties of medullary thyroid cancer is, so this is a cancer which produces, it's a neuroendocrine tumor. Medullary cancer thyroid is a neuroendocrine tumor. As you know very well, if it is a neuroendocrine tumor, naturally it will produce some substances. So each substance carries one MCQ for you. Calcitonin, what are the substances produced? Calcitonin, CEA, ACTH, what are the substances produced are calcitonin, CEA, ACTH, serotonin. So each one is going to carry one MCQ. Calcitonin is used as a tumor marker for follow-up. It is used as a tumor marker for follow-up, and the serum calcitonin is more than 0.08 nanograms per ml. It is positive. More than 0.08 nanograms per ml is positive. CEA is used for prognosis. See, calcitonin is used for follow-up. CEA is used for prognosis. ACTH produces Cushing syndrome for these guys. Cushing syndrome in these guys. Serotonin produces diarrhea in these patients. See, the factors produced by this, each one having some MCQ points. So calcitonin is used for follow-up. CEA is used as prognostic factor. ACTH is causing Cushing syndrome. Serotonin is causing diarrhea. Other factors produced are prostaglandin E2 and F2 alpha is produced. Histaminidase. Histaminidase is also produced from these tumors. So these tumors are therefore a type of functional tumors. So calcitonin is a tumor marker used for follow-up. CEA is used as a tumor marker for prognosis. Since it is more familial, one interesting thing you must rule is you must rule out pheochromocytoma. You must rule out pheochromocytoma in these patients. So because men 2A and 2B syndromes are associated with medullary cancer as well as pheochromocytoma. So rule out pheochromocytoma by measuring 24 hours urinary VMA using urinary VMA. If urinary VMA is elevated, please remember operate pheochromocytoma first. Operate this first. Pheochromocytoma should be operated first before operating for medullary cancer thyroid. So this is an interesting MCQ point you should not forget. So always you must rule out pheochromocytoma, and if it is present, you must first operate pheochromocytoma before operating medullary cancer thyroid. FNAC of medullary cancer 100 times asked MCQ. What is the finding? FNAC of medullary cancer shows amyloid stroma. Please don't forget FNAC of medullary cancer shows amyloid stroma. Shows amyloid stroma for the patients. Amyloid stroma is present on FNAC. Okay, so you must rule out pheochromocytoma in these medullary cancer thyroid patients in case of men 2A syndromes, and also you must do FNAC to look for amyloid stroma. Please don't forget these points. And recent advances in medullary cancer, there are certain recent advances I want you to know. I want you to know certain recent advances. The recent advances on the antibodies. EGFR antibody is now available for these cases. EGFR antibody is now available, and important antibody is vanditanib. So some antibodies are used for metastatic medullary cancers. For metastatic medullary cancers, we have some antibodies like, please don't forget, these are taken from Sabistan. You can get as MCQ. Vanditanib is one EGFR antibody for medullary cancer. And another one antibody is anti-CEA antibody. Anti-CEA antibody is what? It is known as labituzumab. Labituzumab. So these are questions you can get in exam. So vanditanib is an EGFR antibody, and labituzumab is an anti-CEA antibody used in medullary cancer thyroid. Okay, please don't forget these two important recent advances mentioned in Sabistan and Swartz. Swartz and Sabistan, not in Bailey. This is not there in Bailey. It is taken from Sabistan and Swartz. Vanditanib is an EGFR antibody. Labituzumab is an anti-CEA antibody. And treatment of medullary cancer is straightforward. If you get amyloid stroma on FNAC, directly go for total thyroidectomy. No doubt, you will go for total thyroidectomy plus what? No doubt, you must always do central neck node dissection. Central neck node dissection is must. Always you must do. Whether it is node present or not, central neck node dissection is done. And you must do MRND, modified radical neck node dissection, for positive node cases. If there is a node positive, we should do this MRND. So, and I already told you, for men 2A patients, overall men 2A should undergo surgery before 5 years. Okay, should undergo surgery before 5 years. And men 2B patients should undergo surgery before 1 year. So I told you previously in a different way, that's wrong. This is correct. Men 2A patients should undergo prophylactic thyroidectomy before 5 years. This is correct. Please change the previous thing. It's an errata. So men 2A patient surgery is advised before 5 years, and men 2B patient surgery is advised before 1 year. This is from Sabistan. This is again from Sabistan. When will you do prophylactic thyroidectomy? This point is known as prophylactic thyroidectomy. So previously mentioned answer, you must change it. So men 2A at 5 years, men 2B at 1 year, you should do the surgery. So among various pathologies in men to be related medullary cancer will have bad prognosis, will have very bad prognosis in these patients. So please remember medullary cancer thyroid. And I want to ask one neat super specialty level question. So medullary cancer thyroid, what is the most common site of distant mets? Most common site of distant mets. What is the most common site of distant mets in papillary cancer, you told? For papillary cancer, the distant mets is to lungs. Follicular cancer, distant mets is to skull. And for medullary cancer, it is a neuroendocrine tumor. Naturally, they have more mets to liver. Liver is, that's an interesting MCQ. See, from thyroid it goes to the liver. Most common site of distant mets is to liver. Okay, so these are the points you should not forget in medullary cancer thyroid. Then comes the last cancer, anaplastic cancer. Anaplastic undifferentiated cancer. It is occurring in very old women. It commonly seen in old women, and it is an aggressive cancer, aggressive type of cancer. Very bad prognosis, aggressive type. Most of them die within 6 months to 1 year. Bad prognosis, aggressive, bad prognosis. Most of them will not survive even for 6 months. Even 6 months survival is very difficult in these patients. So in this, the interesting MCQ points are FNAC is not diagnostic because it is very hard. The needle will not enter. Therefore, true cut biopsy is accepted protocol. True cut is advised. The most common cause of death is in these cases is patients is respiratory obstruction. Respiratory obstruction is the most common cause of death. So therefore, in old Bailey and all, what they used to mention is if a patient with anaplastic cancer comes to you with a stridor, old Bailey, 26th edition Bailey was mentioning, we must do hysterectomy or tracheostomy. But 27th edition Bailey has changed the point. 27th edition Bailey says, known case of anaplastic cancer. Please understand the point. Known case of anaplastic cancer coming to hospital with stridor. What will you do? Old Bailey was mentioning tracheostomy or hysterectomy should be done. New Bailey says, let him die peacefully. Let him die peacefully. Don't do anything and don't create procedures. Just let him die peacefully. Because he's not going to survive 1 or 2 days also even after you do put a tracheostomy or hysterectomy. So New Bailey says, 27th edition says, if he is a known case of anaplastic cancer with stridor, let him die peacefully. If he is not a known case, at that time he is advising you go for a tracheostomy or hysterectomy can be done. This is from New Bailey and Law, 27th edition. Please don't forget this point. So what is the mutation seen in anaplastic cancer? I told you, P53 mutation is seen, common in old women, aggressive type, bad prognosis, survival only 6 months. So they will die mostly of respiratory obstruction. Don't disturb them, let them die peacefully. Only if you don't know the real diagnosis, at that time we can put a tracheostomy or anything else you want, you can put. Okay. So that is about the anaplastic cancer of thyroid. So about the miscellaneous cancers in thyroid. What are the miscellaneous tumors? So miscellaneous tumors are mets to thyroid. Interesting point. There is a metastasis in thyroid. Mets to thyroid is from where? Mets to thyroid is most commonly from breast. Please don't have any controversy in this. This is a clear-cut question. So it is in the postmortem. In the postmortem, most common cause of mets to thyroid is from breast. Overall, the answer is overall. In men, answer is in males. Answer is most commonly from lungs. No more controversy, no more confusion. That's all. So metastasis to thyroid is most commonly from breast, and in men it is from lungs. In a postmortem dissections, in postmortem dissections, okay? In postmortem dissection, this is the answer. And usually they won't ask anything else. Remember this only. In postmortem dissections, when you dissect thyroid and see, most common metastasis found in the patients is breast cancer mets, and in men is lungs. So no confusion in this. And the type of lymphoma you get is what type of lymphoma I told you? In thyroid we get in old men. It is non-Hodgkin's lymphoma. It is usually B cell lymphoma. It is B cell lymphoma treated by CHOP therapy. CHOP regimen is used. Cyclophosphamide, hydroxyadriamycin, oncovin, prednisolone regimen is given. No need of even surgery. So no need of even surgery for lymphoma, B cell lymphoma in the neck. Just CHOP regimen is enough. If it is a clear-cut lymphoma, we can go for CHOP regimen. This is common in old men. Okay, old men. So this point you should not forget. And final topic in cancer is follow-up protocol. Follow-up protocol for malignancies. After surgery, what are the follow-up protocols? The important follow-up tumor marker is thyroglobulin. It should be less than 5 nanograms per ml. The value should be less than 5 nanograms per ml routinely. So after thyroidectomy, the value will be less than 2, and you have to follow this thyroglobulin level. Please keep this as follow-up. Okay, the value must be less than 5 nanograms per level, and it is used as one value. And calcitonin is another tumor marker. Used calcitonin and CEA are tumor markers only for medullary cancer thyroid. So ultrasound neck should be done in the post-operative period at 6 months, 12 months for 5 years. Okay, 12 monthly for 5 years. And finally, you do PET CT if something is abnormal. So for example, this is a super specialty like question. What is the indication of PET CT in thyroid cancers? In thyroid cancer, I am seeing thyroglobulin level is high. So see, when will I do PET CT? Thyroglobulin level is high, and I am doing radioactive iodine uptake study. Radioactive iodine uptake study is normal. Ultrasound of the neck is normal. Everything is normal. We don't know where is the mets. At that time, we will go for PET CT. So this one finding is for super specialty level. This is for super specialty level. So follow up is with the thyroglobulin level. It should be less than 5 nanograms per ml, or it should be in fact less than 2. Calcitonin CA is a tumor marker. Ultrasound is done annually for 5 years. PET CT should be done. It is showing you thyroglobulin level is increased with the normal radioactive iodine uptake. At that time, you will go for PET CT. Okay, at that time, you should go for your PET CT. Now let us see the PowerPoint of this chapter. Okay. From thyroid cancers, let us see the images which are asked in exams. So Dunhill classification, don't forget, papillary cancer is 80% according to Bailey and Love. So what are the predisposing factors? And men 1, men 2A, men 2B syndrome, I told you. Men 2A, men 2B syndromes. Men 2A will have hyperparathyroidism, medullary cancer, pheochromocytoma, Hirschsprung disease. Men 2B will have mucosal neuromas and Marfan-like habitus, and there is no hyperparathyroidism. So men 2A will undergo surgery at 5 years. Men 2B will undergo surgery at 1 year. Please notice I have changed it and I told it wrongly for you. So this is the correct answer. Men 2A will undergo surgery at 5 years. Men 2B at 1 year itself. Men 2B should undergo surgery earlier. So these are the mutations. I told you various mutations, clinical features of the cancers, and you can see the nuclei. This is orphan nuclei. You can see the nuclei is having no nucleoli. Orphan nuclei. And this is samoma bodies, concentric calcifications. The cancer which can be seen on X-ray is papillary cancer. Okay. So this is orphan. She is an orphan. See, she is a cartoon character of your grandfather days. So now you have so many cartoon characters like Shin Chan, Doraemon, Dora, etc. But in your grandfather days, this is a cartoon. The most liked cartoon by your grandfather is this orphan nuclei. Okay. So regarding the scoring system, don't forget AGS, masses, all those scoring system. What are all high risk factors, low risk factors you can get from Sabistan. Please don't forget the TNM staging I told you. And follicular cancer arising from a long-standing multinodular goiter is shown here. Follicular cancer arising with retrochannel extension. So this is osteolytic skull secondary seen in follicular cancer. All this can be easily treated with radioactive iodine therapy. Easily treated. So Hutchel cell cancer, please don't forget the points I told you. What are the indications of post-operative radiotherapy? Known case of distant mets, extrathyroidal spread, size more than 4 cm, 1 to 4 cm with lymph node mets, high risk histology like tall cell, columnar, insular variants of papillary are the patients whom we give post-operative radioactive iodine therapy. So I have discussed about medullary cancer. All points. Amyloid stroma is clear. Amyloid stroma is showing you clear material which is seen in the FNAC of medullary cancer. So vanditanib is showing you EGFR inhibitor. This is EGFR inhibitor is vanditanib, and you can see this lady with an anaplastic cancer which is showing you bulky growth which is compressing the trachea, and she's about this patient after I took the photograph, she died after 5 to 6 days. She came to us with a stridor, and in spite of tracheostomy, she could not survive. She died in 5 days. So please don't forget, metastatic cancer is most commonly from cancer breast. That is very important MCQ. And neck dissections done for thyroid cancers, you should not forget. So these are the important points I want you to know from thyroid malignancies. So next we are going to the last topic of surgical approach and complications. I hope you are clear with the malignancies. I will stop with the malignancy points here. Okay, thank you.